So what's the indication? So this is the label. So it's a cryosurgical tool for destruction of unwanted tissue. So it's very broad. And under that, it can be used for benign disease, malignant airway obstruction, granulation tissue, and papillomatosis are some of the more common things that I personally use it for. And then just so that we're kind of clear, so there's within sort of cryotechnology, there's cryodiagnosis and there's cryotherapy. And so cryodiagnosis would be the the cryoprobe. You go touch the tissue, pull out the piece of tissue with cryobiopsy, like we all know and hate for interstitial lung disease, or the new kid on the block, which is using it for in the robots or the navigational technologies to get for a nodule. Cryospray itself is really only used for cryoablation. There's not a use in diagnosis. So what is cryotherapy? It's basically the use of extreme cold to destroy tissue with rapid freezing and thawing cycles, and you can kind of control the amount of injury you have by the temperature or the number of freeze-thaw cycles, and then cryodiagnosis we just mentioned, which is the Joule-Thomson effect, and compressed gas going across a metal surface and then freezing warm tissue to it. So what are the differences in the types of cryotherapy? So spray cryotherapy, you can treat a large surface area. So if you just kind of hold still in one area, you'll get about 20 millimeters of coverage, but you can move your hand around. I'll show you some examples of that. And cover a larger surface area. It's non-contact, so you don't have to touch the tissue, and you get a really rapid drop in temperature. And then there's this gas expansion. So one of the things that we talk about whenever we're teaching people how to use this is 1 ml of liquid nitrogen expands to 700 milliliters of gas. So you can see that you have to be able to get the gas out. And then the probe is the opposite. So it's a smaller area of effect. It does require contact, slower drop in temp, and there's one of the benefits of it is that there's no gas expansion. So this is a little bit of history, and I'll show this slide of Dr. Sanderson. He was one of my mentors at Mayo, and one of the sponsors of the bow tie. I really respect him and his contribution. So the reason he's up here is that there was a lot of research that was into cryotherapy in the late 70s and early 80s, and they really pioneered its use through rigid bronchoscopy with probes and then using it for therapeutic applications. Then along comes the YAG laser, and this just kind of went away. And so, lasers are sexy, cryo not so much, but it's, kind of circled back around. With Irby, introducing the flexible probe in '94, and then the GI use of the what's now known as the trūFreeze system, starting back in '07, and then into the airway in the late 2010, 2012, 2013, 2014. You start seeing some of the use of that first generation system in the airway. So cryotherapy is. I'm just going to read this quote. It's although the degree of cell death is similar to those of heat-related thermal modalities such as radiofrequency ablation, argon plasma coagulation, spray cryotherapy preserves the underlying tissue architecture and extracellular matrix. And so this is important because what does that mean? Well, it means that you didn't destroy the foundation whenever you bulldoze the house. And so now you can kind of build back up quicker. And so we've all seen it, like that bottom picture that you see there. So whenever you hit something with a laser or the cautery, that sort of thing, it is really a big thermal injury. And then how the tissue repairs with that is that it's a reparative healing process. And so fibroblasts come in and all this sort of stuff comes in. You get this inflammatory remodeling, which you don't want, because we've had all of these patients that we've treated over the years for like papillomatosis or something like that, and they get a circumferential scar after you've gotten rid of the papillomatosis or the cancer, and now you're dealing with that scar. And so you don't see this necessarily with regenerative healing that happens with spray cryotherapy. So how does it work? Cryoprobe is a sort of a slow healing, and it's mostly by dehydration of the cell, and the freeze-thaw cycles is what causes the penetration of the cell membrane versus the fast flash freeze that you get with liquid nitrogen forms intracellular ice crystals, and that causes the cell to die. We talked about this a little bit. You can control the amount of injury you have by the cooling rate, so how fast it goes. The more injury you get, the thawing rate, how many that you do, the slower it is, the more inflammatory response you're going to bring in, how cold it is, the water content of the cells. So obviously, tumors are very receptive, are very susceptible to this type of treatment. The number of cycles that you do and the sensitivity of the tissue. And so like cartilage, collagen, elastin, all those sort of things, nerve, those are all very relatively cryo insensitive. I'm going to skip that. And then we'll just talk about the ablation zone. And so what happens is that whenever you have this spray that comes out, so we talked about, I call it the rule of twos. So your catheter's 2 centimeters out, you're about 2 centimeters away from the lesion, and you're going to get about a 2 centimeter surface area if you hold really still. But then by moving or painting back and forth, you can really sort of equalize the amount and depth of injury. If you stay just on one spot, you'll go deeper. If you move it back and forth, you'll have a more uniform distribution. We talked about that. So things that are cryosensitive, tumor granulation tissue, et cetera. 2 platforms are out there. The trūFreeze is on the right, which is a spray, and it uses liquid nitrogen as opposed to the probes, which use typically carbon dioxide or nitrous oxide. Cold, so you can deliver this at safe energy, or with high oxygen levels. You have to worry about a spark causing a flame. One of the things that's really nice is you can deliver it around stents. A paper just done that looked at its effect on stents, and there was really no structural problems with the stents. Minimal cartilage injury, so minimal scarring, minimal stenosis afterwards, and then the relative bioselectivity for tumor tissue, which is pretty nice, or the inflammatory fibroblast. This paper was done as sort of a whenever you've heard about the Rejuvenaire, which is a different company, CSA, but it's still metered cryospray for chronic bronchitis. And so this was an ablate and resect. And so they went in, sprayed whichever lobe that was going to be resected, and then they went back in and resected that and said, okay, what's the effect on the tissues? And so what they found was that, number one, it was really hard for them to find where they treated because they didn't leave a marker behind, and so the tissue was pretty normal visually on bronchoscopy. And then whenever they resected it, the pathologist, ended up kind of going through the area where we thought, where you thought it was, because all the tissue looked normal, and so that's a really normal. This area was completely ablated, and so now you see a normal, columnar respiratory epithelium, normal basement membrane, normal structures, that sort of thing. So again, the reparative rather than the damaging healing process. So this was one of the first papers that were published using the first generation of the cryospray system, which was basically sort of taken almost like directly out of the GI system, and then said this is a good idea. We can try it in the airway and see what happens. And so it was, I think, it's probably responsible for the fear, appropriately so, that people have of cryospray. And so in this trial, there were 21 intraoperative events, and so mostly cardiac. And so this is like the diving reflex, right? So cold, bradycardia, you spray it on the carina, there's going to be more likely that it's going to happen. They got ST segment changes. There were 3 pneumothoraces, 2 intraoperative deaths, and then 79 of 80 had patent airways at the end of the case. But you can see that, this is, it's like, whoa, okay, what's going on here? And so then there was a pause, and they said, okay, what is going on here? And then the next generation of the system gets introduced, and you can see it's completely different on the safety profile. So this is Dr. Browning and Parrish's work at Walter Reed. And so This was their early experience from 2011 to 2013. 27 patients, 80 procedures, all had malignant or advanced disease. They all underwent procedures in the central airway, so not going out into the lobar, bronchi, that sort of thing. It's one of the other things that was noted that this is and you'll see that whenever you're using this in your practice, this is a combo technique. So you're going to use this with something else typically. There were only 3 complications, and those were all transient hypoxemia. So you can see with engineering, changing of the catheter, changing of the flow rates, and then making a system that's designed for use in the airway really had a profound effect. This is another follow-up trial in 2016. This was out of Temple. Dr. Abbas was a thoracic surgeon there. And so this was a combined of benign stenosis and malignant stenosis, or malignant obstructions. And so I've blocked out the benign ones, and so we'll just focus on the malignant. Is that very effective at changing it was sort of the Cotton-Meyer classification at getting their final grade of stenosis changed by 2 points or so, from going from a 4 to a 2 on average. And then also notably, only 1 in 22 patients had any effect, and that was basically a guy who was 7 months post-transplant, needed to be reintubated in the PACU because of hypoxemia. And the authors felt that it really wasn't related to the spray cryotherapy at all, but more anesthesia. We always blame it on anesthesia, right? What are some of the limitations? Delayed hemostasis. This is something that you think you do something that's really cold, it'll help with the hemostasis, and it does, but it's pretty messy. And so you occlude your entire channel, you get down in there, and so I haven't found it to be very helpful with the delayed hemostasis. And this cryoprobe with freezing and thawing, it really takes a little while for that constriction and infarction to take effect. With the spray cryo, there's delayed slough. So you need to do, if you have a high-grade obstruction, you need to do something else to make that airway not critical, because you're going to get swelling, you'll get slough, and then kind of like for those of us that have used PDT in the past, you'll see that you'll need to do that clean out bronch if you leave a sort of a very small airway. And this is, again, just with malignant disease, not necessarily with benign disease. And then it can freeze your bronchoscope. The first time you get I call it a scope sickle, it's like, whoa, is it going to recover? And as far as I know, I haven't damaged any scopes, but they're very frozen at the end of the case. So just delving into a little bit of the procedural considerations of this, and I'll show you some cases, is that, again, we talked about this barotrauma risk. So we spend a lot of time making sure that you have an open circuit, so that you have a big enough endotracheal tube, or using a rigid bronchoscope, or you're doing an LMA, you disconnect the ventilator, you let the cuff down on the endotracheal tube, and then you're really monitoring for chest rise, you're making sure that the gas is coming out, you're doing a lot of safety things. And Dr. Sethi will talk about another thing, which is the low flow setting that also minimizes risk of barotrauma. Another thing to keep in mind is that this is the opposite of a nitrogen washout. This is like an oxygen washout. So whenever you're spraying this, you're going to be limited on the number of times that you can do this because you're basically washing the oxygen out of the FRC. So if you have somebody that has limited FRC already because of obesity is the big one I see, you're going to be limited in the number of sprays that you're going to be able to do. So on the right-hand side, so we talked about the proximal to distal, and so you can see that you can't see the tip of the catheter on this, and so this is a guy that has vanishing bronchus syndrome post-lung transplant. The right upper lobe is up and to your right at 1 o'clock on the screen, and so I'm in the right upper lobe, and I've put this down to his stenosis, which is in the distal bronchus intermedius, because if I would have wedged the scope to get closer to where I could see it, I would have caused barotrauma, and the gas wouldn't have been able to come out. And so that's one of the ways that you can sort of treat a more distal airway. Wouldn't recommend that you go out and make that your first case. I like this case because this is a fellow that was a veterinarian in Kentucky, got squamous cell carcinoma in his larynx. So we're right at the cricoid cartilage. And he's already had all the radiation that he can have. And so now we're doing this. And this is something that you would never do, treat circumferentially or hit the posterior membrane, that sort of thing, with any of your hot therapies. But this is very safe with cryospray. And you can see that we can treat a very large area, and we can get about 2 to 3 millimeters of penetration. And so then people come back for another. And so again, very safe to use. One of the things that's kind of nice about carcinoids, so, we've all seen these benign carcinoid tumors, and somebody has a lesion at the crine and they get a crinal pneumonectomy for a benign carcinoid tumor, because that's kind of what was out there. And so this paper kind of talked about using spray cryotherapy, or using probe cryotherapy for people with endoluminal carcinoid. And basically what they showed was that they were able to either cure those people or decrease the extent of the resection, and with fairly long-term follow-up. This is a guy that came to me, and he's sent by the surgeon with a left mainstem carcinoid. It was a little bitty tiny stalk, about 2 millimeters, just down in the distal left mainstem. And so we removed that tumor, and then you can see that stalk right there that needs to be treated. This is an area that'd be very difficult to treat with like a YAG laser, right? So you could treat it with APC, you could treat it with cautery, but if you're going kind of straight at it, the angle is going to be very funny. And so I can apply, probably 3 or 4 times the joules to that area with cold energy, and right at that carina. And so this was one of the first cases that I did back in 2015, I think. And so he has never had to have a carinal pneumonectomy, and no evidence of recurrence. So 47-year-old lady, and this is a tumor. She had chronic cough and asthma, and turned out that it was a carcinoid, distal left mainstem bronchus. You can see where it was attached right there to the LC2 carina. Right in here. Does my mouse show up? My mouse doesn't show up, but let's put on the laser. So right there is where it was attached, and you can see the treatment effect. And then here it was, 5 months later. I see her every year up until this point, with no evidence of. I think I got a picture of it there. Yeah, so we treated that area with that had the residual disease after we removed it, and I just saw her about a month ago for her annual bronchoscopy, and there's still no evidence of disease recurrence. She was going to get a pneumonectomy for that tumor. Another typical carcinoid tumor, also involving the LC2 carina, offered a pneumonectomy, sought a second opinion. She was a medical student at the University of Tennessee, and we did spray cryotherapy on her, and you see the far right image, you can't even really tell that we were there. If I'd have treated that with hot therapy, we would have had some scarring or effect. Safe to use around stents. We didn't need to remove the stent in this case. And then just to kind of summarize things, very safe, been well studied, just as long as you adhere to proper technique. Very favorable tissue repair response. Outcomes are very similar to hot therapies. I think that personally it's underutilized in interventional bronchoscopy, but we do need some better data. And if anybody fell asleep, the only thing you need to remember about the differences are these. So this is cryoadhesion. There you go. And this is spray cryo. There you go. All right. So, okay.